Greetings and welcome to the On Becoming a Healer podcast. I'm Stefan with my co-host Saul Wiener. In each episode of this podcast, tell stories from clinical practice that bring up themes of engagement with others, boundary clarity, healthcare decisions, humility, and other attributes necessary to becoming an effective healer, including realism. Hello, Saul.
Hey, Stefan.
How are you doing?
I'm doing well. So what are we talking about?
Well, I want to tell a story from the recent past that brought up a number of issues for me, and I just want to get your reflections on them.
Sounds great.
In the last year from, let's call it Cashlack Memorial Hospital, I was working in a hospital with medical residents, and overnight before my team received patients, someone came in who wanted to enter addiction treatment. It was a guy, he had been homeless, he was living on the streets with a woman, a pet, and someone else who was either a sibling of the woman or a friend. And he came in saying he'd been using both heroin and alcohol, and he wanted to enter a recovery program. And he came before I got there on a Friday morning. And after some deliberation, we started some medications to try to prevent withdrawal from both the alcohol and the heroin. And
Did he give any indication of why he wanted to enter a recovery program?
oh, yeah. He said that he wanted to be able to better protect and support the woman who he cared about and put his life back together, basically.
Okay.
So the issue with somebody who wants to enter addiction treatment that is a residential treatment program, which would seem more appropriate, I guess, for somebody who's homeless, is it could take a little time to set up. So our order of business was to make sure that we prevented him from going into withdrawal while talking with social work and mental health professionals about, well, where would he go? So that happened over the course of a day, and no final conclusions had been reached. And I left the hospital around 6 o'clock in the afternoon. And as I was halfway across the street on the way to the parking lot, I got a page from somebody inside the hospital saying that he wanted to leave. So at that point, I had a surge of concern because throughout the entire day, I had been nervous that we had not offered sufficiently high doses of medication to prevent withdrawal from the heroin. And the medical residents I work with love to use a short-acting medication to treat alcohol withdrawal called Ativan. And I generally am much fonder of long-acting medicines that don't wear off quickly, like Valium. And I just was very nervous as I went back into the hospital, took the elevator up, thinking to myself, people leave because withdrawal is poorly controlled. Thinking to myself that this was going to be a situation where we had failed to treat withdrawal, and he was going to want to leave because we had screwed up.
Sure. I mean, that sometimes I've seen that where a patient says they want to leave for whatever reason, but what's really going on is they're miserable physically.
So I get to the room, and in fact, the patient looks sort of agitated, irritated, and he's anxiously texting somebody on his telephone. I sit down and I say, I hear you want to go. He makes clear, yep, he does. And he says, I'm really concerned about this woman who I've left on the street and the pet. I can't remember if it was a cat or a dog. And frankly, this other individual can become quite nasty when they're drunk, and I don't know what's going to happen tonight. I feel like I got to go. And at that point, I said, I hear you, but I am worried that maybe we made a mistake here in terms of preventing withdrawal from alcohol and drugs. And I laid out the case to him as to why we could have done it better. And he took it very well. He said, yeah, what you're saying makes a lot of sense. I respect it. I hear you, but actually, I really got to go. And I think it's important for me to do that. And for me, this was just like a 180 in my head. Like, okay, he's saying I'm right, but he's saying what I'm saying doesn't matter at this moment. It really is that he's just got to go. And I offered new medications. No. And so sitting there next to him, I'm watching him text. I'm seeing he's anxious. I said, well, we can give you medication right as you leave. He's like, I got to go now. I could give you the phone number for the social worker who you could call. He said, sure. And we actually took the elevator down from the hospital and walked out together. And it was actually a pretty friendly departure, really. At that point, I had essentially corrected in my mind the notion that it was something I could fix, that this was his choice. He was going to make this choice. I needed to accept it. But I'm still wrestling with the case.
So what did he tell you was his reason for wanting to leave?
That he was concerned about the woman he was staying under the bridge with or under the viaduct with, and that he was a little concerned about the pet, and he was concerned that there was another person who was sometimes with them who could be abusive when they got drunk, and he wanted to protect that individual.
Now, what's interesting is when you started to tell this story, where I thought this was going which is also, I think, an important and interesting issue, is that sometimes we undertreat patients who are going into withdrawal. And what happens is they want to leave AMA, and we get frustrated. We think that they're not doing their end of the bargain to get well. But in fact, what we've done is undertreat them. And obviously, if you undertreat people who are going into withdrawal, they're going to be so miserable, they're going to leave. And it sounded like that's where you thought this was going initially. And you had some doubts about whether he'd been treated adequately. But then when you got there and you had a conversation with him about what you were thinking, he sort of said, well, you've got a good point, but that actually isn't why I'm leaving. I'm leaving because I'm worried about this woman who I'm not sure if it's his wife or his girlfriend or whatever, the woman who he's or a friend that he's out on the streets with. And again, I think you said there was another guy who he's a little concerned about, might be abusive to her if he gets drunk. And then there was a cat or dog. So there's just a lot going on there. And it sounds like he was really saying genuinely that he's leaving because he doesn't feel like those folks can be left alone at night. That was your impression?
He basically said, sure, doc, you're right about withdrawal, but ultimately this is my call. And I think, I know, I hear you and I've just got to move on. It was sort of, yes, you're right. And I have to go because I have real concerns here. And I had to make this sort of, it was like a little bit akin to, because I was walking in thinking we've really screwed up and I got to fix this. It was like slamming the brakes on my own truck from 60 miles an hour to zero and getting to stop and saying, okay, I hear you. You're making a decision. It's not crucial what I had decided as I walked in. It's crucial what you're deciding now.
So now, when he decided to come into the hospital, as you mentioned, it was to get residential treatment with the long-term plan of addressing his addiction problems so that he could return to work and support the folks he's been out on the street with, in addition to take care of himself. Hopefully, or presumably, he had thought about the fact that he was going to be in the residential treatment center for some period of time, certainly more than 24 hours. And then now he's telling you that he's got to leave because he feels like this woman can't be out on the streets alone overnight. And so I guess I'm curious, was that because of something that he learned after he came into the hospital? Was there some disruption, something new that happened? Or was he not telling you the whole story? Had he not worked this out? I'm curious, is this something that you, because, on the surface, it doesn't make that much sense, right? That if you think you're going to go into a long-term program, and then all of a sudden you're like, actually, I can't stay here more than 24 hours. Those two things don't quite add up. So was that something that you talked to him about?
Well, and now we get to the nub of the problem because I didn't. And it's really intriguing that in the moment sitting up there with the individual, watching him text, absorbing the change of understandings that I was undergoing, I never said, hey, this clearly would have been an issue when you came in yesterday night. What was your thought about it at the time? And is there something that made it change? I never asked that. And it's really an interesting question. Why didn't I ask?
Well, a couple thoughts come to mind. One is you mentioned that you were already kind of doing that 180. You'd come up there with this hypothesis that this was a guy who wasn't getting adequately treated for withdrawal. You were kind of preoccupied with that. I know you, Stefan, you tend to kind of obsess over, am I the perfect doctor? Am I doing anything that's less than perfect? Things aren't going well. I must be screwing up. So you were kind of in that mindset, which is, by the way, true of a lot of physicians. Physicians tend to be often perfectionistic. They often tend to be very hard on themselves. And then all of a sudden you get up there and you discover, at least he seems very genuinely to be saying, no, doc, that's not really what this is about. It's really just about stuff going on in my life. And so you were able to make that adjustment. But then you kind of stop there. Just to give you an analogy, let's suppose, we made plans for me to come down and visit you in Birmingham for a few days. And the plan is I was going to come down there for a week. And, you're going to show me around. I'm going to spend some time with your wife and your son and so forth. And, we're all good to go. We make plans and I show up. And the next day I'm just like, Stefan, I need to get back tonight. And you're like, why? And I'm like, well, because I have to be at work tomorrow. I mean, there's a big project and I just can't leave that project. I'm critical for it. That project is going to, let's suppose it's a grant. It's never going to get in on time. And so, I just all of a sudden say this to you. Would you just be like, oh yeah, sure. Okay. That's good to know. Let me get you to the airport. I'm guessing you'd probably be like, what?
Yeah. There's two different frameworks. There's apparently, and we're just discovering this now, right? But there's one framework, which is my friend who's come down from Chicago. And I'm like, wait a second. Clearly you thought about this before you came down. I mean, this must be a thing that you're going through right now. Could you tell me what changed? And then apparently I have this entirely different way of thinking when I'm talking to an individual called a patient, which is like, oh, well, if you have addiction, Maybe it's because they have addiction. Maybe it's because they're a patient. Decisions will just change suddenly. And my job is to sort of say, wow, that's really deep and serious. And I respect that. And not to ask the obvious question. And I wonder how often that happens.
Yeah, I think this is a really interesting thing. And I think you really put, the nail on the head when you said when it's a person we call patient. Because I think that with patients, we just tend to sort of say to ourselves, oh man, they do all kinds of crazy stuff and, whatever. And yet, as common as that is, it isn't respectful. Respect is just sort of giving the person the same due credit, starting with the premise that they have their reasons. And, for example, this guy, assuming he was telling you pretty much what's going on, might be someone who could be helped. Like, for instance, let's suppose that is, in fact, an issue that he's concerned that when he stays in a residential treatment program, that she's going to do badly out in the street and that this other guy with her is abusive. Maybe she needs to go get into a shelter program, a women's shelter program. Maybe a social worker could help out with that. There are a lot of things that maybe you could kind of problem solve with him. There are a lot of potential things that could happen. But, when we put this in the context of some of the themes on becoming a healer, it brings to mind this concept of boundary clarity and engagement. So it seemed like you achieved boundary clarity. By that, I mean that you were able to get past just interpreting all of this in terms of your own anxieties about whether you'd been a good doctor had you undertreated this guy, and you were able to, that had been you'd been preoccupied with that. And then you kind of came around and recognized that, yeah, no, this isn't really about me. This guy just really has some social issues going on. And that was an achievement. You kind of achieved that boundary clarity. But what I would say in sort of using this terminology is that you didn't achieve sort of full and open engagement. Full and open engagement is when you respond to the other person in the same way that you would respond to anyone who you just assume is a sensible, reasonable person until proven otherwise. And to do less than that, it is a certain form of labeling. Labeling as what you call patient, crazy patient. And so I think this is just kind of a good example. And I think that boundary clarity and engagement are yin and yang, which is to say that if we're struggling with boundary clarity, it tends to make it more difficult for us to fully engage with patients because we're not fully responsive to the situation as it presents itself. We don't take everything at face value. And I think this is just kind of a good example of that, if that makes any sense.
Yeah, I think it's worth saying that this process of stopping my own level of fear that we had screwed up in the management and doing that from walking in at 6:00 in the evening, thinking I still want to go home, rapidly correcting that concern kind of blocked my awareness of asking the common sense questions. And I don't feel, I'm not saying this as a mea culpa in some grand sense, but I think under ideal circumstances, one sort of walks in, hears what people are saying and says, oh, that's really interesting. Why do you say that? And I didn't really do that at that moment. And I think oftentimes when we respectfully acknowledge a person's preference, we sometimes do it in a very benign way. We say, I respect and I honor this individual. But asking why is also part of respecting and honoring a person. And it was hard to do in the moment.
Yeah. And one thing I found that's also challenging, and I've seen residents struggle with this, is how you actually formulate the question. Oftentimes I find residents are afraid of seeming like they're challenging the patient in some negative way, or they're escalating conflict, when in fact they're simply asking a rational question, which quite honestly, I see as an act of respect, not an act of confrontation in this situation. So I'm just sort of curious as to how you might ask that question, given what you remember about this guy. If you had sort of a do-over, what might you say?
Yeah, I think that I would say, I realize how much you care about the person that you're out on the streets with, and the concern you have for your pet as well. And I'm imagining you must have thought about that even before you came in yesterday. And I want to know, did something change? Did something come up that really changed your sense of their vulnerability between yesterday and today? And then if he says, well, I just suddenly recognized it, let's imagine he says, I got a text message, I suddenly realized just how serious the stakes are. The next question is there a process we could do, or is there steps we could take that would make that less of a concern the next time? And should we make sure that part of our follow-up to your stay here this time is that we know who's going to help us the next time? What do you think?
Yeah, I think that's nice. I don't think there's a right way to ask the question. I think there is, we each find our own way to ask the question, and that's an approach you would take, which I think is great. I think that the point here is that each of us finds our own approach to asking patients about why they're struggling in a particular situation. I think the general approach is to start with an observation, what you observe, and then to follow it up with an open-ended question. But how we do it is really something we have to figure out for ourselves. I think the key here, though, is that we need to do it.
I agree completely. And I've really valued just the chance to converse about this case. I like the fact that I changed how I was thinking in the moment. And I like the fact that I'm getting a chance to think about this one again so that I can do a better job next time.
Well, that was a good opportunity to talk about some of the themes of our podcast on Becoming a Healer. And let me just close by asking you if there's anything else you want to add.
Well, as a friend, but also as a fan, I would say for folks who are interested in exploring these themes in a deeper way, I strongly encourage you to take a look at the book on Becoming a Healer by Dr. Saul Weiner on this podcast. And I'm thankful for the chance to discuss this.
Well, thank you for the plug. And to those of you who are listening, if you haven't already, please consider subscribing to our podcast.
All right. Take care.
Take care.